करो, खत्म करो।
Ma'am, we are good to go.
Yeah.
Good evening, all delegates. Myself, Raja Rajeshwari, Product Manager from Emcure Pharma. It's our pleasure and honor to participate in this wonderful webinar. Thank you so much for accepting our, making us a partner of this event. Thank you so much, doctors. Over to you, ma'am, Shilpa.
Yeah, hi. So on behalf of Infertility Committee of KSOGA, I would invite all the participants and the faculty for this wonderful webinar. So it's my honor to have our President and Secretary of KSOGA, Dr. Vidya Tobi ma'am and Dr. Rajeshri Palladi ma'am, and the very, very esteemed faculty. I invite Dr. Kavita Bapat ma'am and the other speakers today. So it's really our honor to have you here to deliver your talks. So the master of the ceremony today is Dr. Shobha. I think she has joined. Shobha, you're there? No, not yet.
No.
So I would like to welcome our President of KSOGA, Dr. Vidya Thobi ma'am. So can we have madam's this thing? Vidya Thobi ma'am. Yeah, madam is a very senior gynecologist, and she is the president of KSOGA, which is a very, very active and vibrant society of Karnataka. Madam has been in Foxy, and she has held various positions in Foxy and also at state level. And madam has a vision about anemia and also in various other aspects. So I would like Dr. Vidya Tobi ma'am to give her welcome address today.
Mr. Join Karo, I'll rename myself and share my slide. But anyway, I have sent no, let her do it. In case I get stuck, then
Vidya Tobi ma'am is there?
no, she's traveling, Shilpa.
So you can give Rajeshri ma'am.
Yeah. Pranamam, everybody. Welcome to the session of an interesting talk of interactions of infertility and also a very practical topic of day-to-day interest by Dr. Kavita Bapat. And as we all know, anemia is rampant. Anemia is there all the time, and we can never move on to anything without having talked about anemia. I welcome you, ma'am, Kavita Bapat ma'am, for this session. I take this opportunity to thank our president, Dr. Vidya Thobi ma'am, who's always been supportive of all the activities that we are doing in KSOGA, and it is under her leadership that we are doing more and more. We are completing nearly 100 days now, having taken up the reins of KSOGA as a president and secretary, and we see that there are many interesting sessions going on. I take this platform to also thank all our esteemed faculty who have joined today, and hearty welcome to you, Dr. Asha ma'am, Dr. Deepak sir, Mahesh Koragal, and I think Dr. Shobha Gudi will join, Anupama Patil, and all the respected dignitaries who have assembled here, and all the faculty members and all the delegates who have joined in to listen to an interesting session. Thank you so much for joining. Over to you, Shilpa.
Yes, ma'am. Yes, ma'am. So thank you, Rajeshri ma'am. Hoping to have a very fruitful discussion today from your end also. And we'll go to the first session now. I welcome our chairpersons, Dr. Shobha Gudi madam and Dr. Anupama Patil madam. So can we have their CV, please?
Yeah, just a second.
Yeah, Shobha is here. So Dr.
Yeah.
The MOC, so she will cover the. Shobha, you take.
Yeah, Shilpa. Sorry for the delay, guys. Because of the some network issues, I was a little late.
No
Sorry,
problem.
I'll just I'll just start.
Shobha,
Yeah, Dr. Shobha N. Goody, ma'am. She is an MD from Jawaharlal Nehru Memorial Medical College and DNB. She is MBBS from Jawaharlal Nehru Medical College, Fellowship of Indian College of Obstetrics and Gynecology, past BSOG President, Foxy Safe Motherhood Committee Chairman. Ma'am, we welcome you, ma'am. And one more chairperson is Dr. Anupama Patil. Anupama Patil is a consultant in infertility and reproductive medicine at Kriti Fertility Center, Gadag, and she's MBBS from KIMS Hubli, fellow in reproductive medicine, Milan Hospital, Bangalore. We welcome both the chairpersons and take over the sessions.
Hello.
Hello, can you hear, ma'am? Shobha, ma'am?
Yeah, I can hear. Hi, everyone. Hello, everyone.
Hello,
Sorry,
ma'am.
I had connectivity issues. Hello, Asha. After a long time, I'm seeing you. Hi. And Rajesh.
How are you?
Hello. I'm fine. Hi, Bharti. Hi, Bharti.
Namaste to everybody. Shobha, Rajeshri,
Yes.
Asha Lata.
Namaste, ma'am.
I
Namaste.
can see
Namaste.
Dr. Nagesh
Mahesh.
Kumar also. And
Good evening,
hi,
madam.
Mahesh.
Dr.
Hi.
Kavita. Namaste, Dr. Kavita, Dr. Dipesh.
I was thinking, let us say welcome to Kavita in a grand way. So I was not taking her name as yet. So
Dr.
I think
Nagesh, namaste.
Shilpa, you introduced,
madam.
I think, no?
Yeah, ma'am. Can you please introduce Dr. Kavita, ma'am?
Thank you. Okay. Because I joined a little late. I didn't know what was happening.
I'll just share Kavita ma'am CV.
Yeah, Shobha, please do that. Yeah, can you make it full screen? Yes. Well,
Ma'am, can you see? Yeah.
of course I can see.
Yes.
And it is this CV actually is not doing justice to Kavita's volume of work, but I will try to make the best of what is there. Please go back. Yeah. So Dr. Kavita Bapat is actually no stranger to KSOGA. We are so delighted to have her here. She has been the vice president of Foxy 21-22, and that happened to be my last year as chairperson in Family Welfare Committee. And it was a fantastic experience working with her. Very, very dynamic and very spontaneous person, and very transparent, very warm. I think those are her personal traits, and all of you are aware. I need not say, because she interacts one-to-one with everyone that she comes across. Thank you, Kavita, for making time for KSOGA today. You were the organizing secretary for AICOG 22 Indore, and you made history because you faced a lot of difficulty in the pandemic, but still you did it. You are also known as the daycare hysterectomy specialist. You are also expert in vaginal surgery, and you run a certificate course at your center. You are a peer reviewer in Jogi, editor for other journals as well, and you have won several awards, including the Naika Indore and Captain of Industry. You are also running the Menopause Society in Indore, and I think EC member of ISAR and IAG also. I didn't know that you are EC in ISAR and IAG. That is great. And of course, you have
governing council also.
Yeah, governing council in ICU.
Of ICOG also.
Yes, 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 yes.
Thank you so much, na.
Yeah.
Thank you so much. Let me
So
allow.
you are welcome now to present your lecture, and a very warm welcome to you, Kavita.
Thank you so much. Allow me to share the screen so that I can start my presentation. And thank you so much for being so cordial, everyone over there at KSOGA, especially the Rashli and the Shobha and Asha is there. And nice to see Dr. Nagesh Kumar over there. Allow me to share the screen so that by that time I can, thank you so much. Just make it a point. Is it visible?
Yes.
The subject given always been a fun to me. Reason being, there are less number of people in webinar, but anemia is anemia. I'm telling you, nobody can beat it. This country needs to revolutionary change into bringing the anemia go down. It's really very, very important. And I'm always proud to say that I come from a place called Indore, which is the cleanest city of India. And with the same conscious and clean mind of mine, I am contesting as the post of President Foxy. So, though not going into detail of anything, so anemia in pregnancy has been given the subject. I was a student 35 years back. At that time also we used to talk about anemia in pregnancy. Until date, again, we are still talking on the anemia in pregnancy. It means this subject is not going to finish. And this is our responsibility to eradicate, eliminate all the things we should do. So more than 1620 million people are living with anemia. Prevalence of anemia during pregnancy, 41.8. 56.4 million pregnant females are this, and India especially 52.2% are there. Why we talk about it, anemia in pregnancy, is very important. It's not a simple anemia which is troublesome. Anemia makes so many problems into the pregnancy, and that's more important. And that's why we talk about anemia. So number one thing is, when we call it an anemia Mukta Bharat, there are guidelines, and there is a definitely WHO definition which says anemia less than 11, mild is 10 to 10.9, moderate is 7 to 9.9, and severe is less than 7. All of us know I am not telling something extra robotic science or something, and I am going to take very simple things which will be a take work messages, and that's more important. So why iron deficiency anemia? There are 4 things are there. Either there is a decreased iron absorption, or a demand is increased, or there is a blood loss, or there is a decreased iron intake. When the iron absorption is decreased, it can be celiac disease, malabsorption, chronic inflammatory diseases, malignant diseases, or a concomitant intake is less. And what is the increased demand? Because of the pregnancy, lactation, infancy, adolescence, and endurance sport. And decreased iron intakes can be because of the vegetarian we are, unbalanced diet, eating orders, disease-related anorexia, and most important, the blood loss, heavy prolonged menstrual bleeding, delivery, gastrointestinal bleeding, surgery, and donation. So this is the most common causes of iron deficiency anemia. And this is the requirement which we need to have the average daily absorption, 1 to 5 milligram, and Indian diet, it is only 0.8 to 4.5 milligram per day. So what are the consequences? Why we are worried about anemia, why we talk about it? So number one is the antepartum complication. Number one is the increased risk of preterm delivery, chronic placental insufficiency, premature rupture of membranes, preeclampsia, and intercurrent infection, antepartum hemorrhage, and cognitive heart failure. But when it comes to the fetal outcome, low birth weight, prematurity, spontaneous abortion, fetal death, infection, congenital malformation, neonatal anemia, growth retardation, and abnormal cognitive development. So maternal anemia contributes about 18% of perinatal mortality and 20% of maternal mortality in all the Southeast Asian countries, including India. And most important of the anemia part is abnormal cognitive development as a fetal outcome. Take it a point and you can be sued. Anybody can come into your office that 25 years back, I was delivered into your by you, and my mother's hemoglobin was very less and my IQ is now only 90. So you are responsible for all those things. So make it a point very clear that we should treat the patients of anemia during pregnancy so that in next 10-15 years, you should not be sued by young kids of this country. So what is more important? We need to do the history and a clinical examination and very simple diagnosis of iron deficiency anemia. Again, it's not a robotic science. It is not something very big thing. Just do 3 things, MCV and RDW. It is characterized by low MCV, low MCH, and this is accompanied by elevated reticulocyte count. So 3 things are very, very important when we talk about the iron deficiency anemia. And it's a simple CBC I am talking. Low MCV, low MCH, and elevated RDW. And this RDW, we can differentiate it because it is when it is decreased, it is thalassemia. When it is increased, it is iron deficiency anemia. Very simple, and anybody can talk about it. So serum iron and TIBC are the unreliable markers. And we should, the country like India, we are not reliable on it, and we are not running in each and every case. So simple CBC, low MCV, low MCH, and elevated RDW. I'm just surprised, and there is no in a GCPR or any guidelines that we are doing thalassemia testing in each and every patient of this country. And why we are not doing is surprising. We are doing the costliest test at the 16 weeks, double marker, quadruple marker, and whatnot, from the PAPAS test and everything we are doing, but we are not testing the thalassemia in this country. The thalassemia is 1 in 80 and Down syndrome is 1 in 800. So this is very important, that the RDW is important thing is, and this iron shows a diurnal variation and it influences, and pregnancy itself increases the total iron binding capacity. So no use even in the, so iron, serum iron and TIBC are not important. Serum ferritinine, again, cutoff is 30 micrograms per 100 ml, and the diagnosis and treatment of the iron deficiency anemia. So when to do the serum ferritin in pregnancy? It's prior to start iron therapy in patients with known cases of immunoglobulopathy or prior to parenteral iron therapy to confirm iron deficiency. So not in each and every case, and it is alternative etiology of microcytic anemia is being considered, and that's the big thing. An increased risk of iron depletion may be due to the previous anemia, multiple pregnancy, teenage pregnancy, pregnancy with high risk of bleeding, and consecutive pregnancies are there. Now, iron supplementation, that we can put it in a 3 category, either dietary iron. I'm not going to talk a single line about dietary iron. We all know oral iron has got its own problem, and today I'm going to talk a little 4-5 slides about the parenteral iron. So oral iron supplementer, it can be either bivalent or trivalent. The whole life we are treating our patients with the demand of our pharma correlatives or relatives, you can say. Sometimes they talk about ascorbate, sometimes fumarate, sometimes sulfate, sometimes glycosinate. But and trivalent about the iron polymaltose complex or ferric ammonium citrate. Again, the take work message is absorption of ferrous iron is more than 3 times than the ferric iron. So the ferrous iron are good. Again, there is a limitation of oral iron, poor absorption, reduce the certain medication, food intake problem, inflammation, making the treatment time consuming, months to correct anemia and replenish the iron stores. And the main issue of oral iron therapy is reduced compliance due to the associated gastrointestinal effect like bloating, diarrhea, heartburn, nausea, constipation, and dark stools. And oral iron requires comparatively longer time to rectify anemia and restore the iron. So there is a limitation of oral iron, and oral iron therapy does not sufficient for the treatment of moderate to severe anemia, especially into the late 3rd and 2nd trimesters. So the role of parenteral iron therapy comes. Why we do the parenteral iron therapy? Number 1, it's a failure, non-compliance, late 2nd and 3rd trimester with a moderate to severe iron deficiency anemia. Sometimes there is a malabsorption, sometimes there is a bleeding diathesis, and in combination with a recombinant erythropoietin, patients with a pregnancy and a chronic diseases. Moderate to severe postpartum anemia when compliance of the oral and follow-up to the healthcare facility is doubtful. So how parenteral iron therapy and where it are the contraindication? Number 1, when the facilities of resuscitation is not there, it should not be given. When there is a known history of anaphylaxis or the reaction of parenteral iron, it should not be given. And if the gestational period is less than 12 weeks, it should not be given. Various studies have shown that the ONS indicated intravenous iron therapy is superior to oral iron therapy in terms of speed and absolute extent of the hemoglobin increase. So parenteral iron, see that this is a simple iron. Basically, there is a carbohydrate outside the carbohydrate, and inside there is a iron oxyhydroxide. So simple thing, carbohydrate shell stabilizes the molecule and show a slow release of elemental iron. So how it works? There are 4 types of iron. When we were student, at that time, iron dextran was very popular. A big injection given into the gluteal muscle, and lot many problems used to happen. A blue color and whatnot used to happen. Then iron sucrose, multiple doses, longer time of administration is there. Then now these two have come, then the FCM and iron isomaltoside. But FCM is superior iron and it is single dose, low risk of hypersensitivity. Iron isomaltoside contains, though it is having the reduced dextran, more liable iron is there in compared to FCM, but there is no studies have been for the different indications. Now, these are the properties of the parenteral iron. When we talk about something ideal, who is the ideal person for ideal things are there? There is nobody in the world is ideal, but some people are very close to ideal. Same with the FCM, because it has got more than 1,000 molecular weight. It has got a stability high. Its half-life is long. Its pH is neutral, near neutral. Its osmolality is isotonic. Antigenicity is low. Test dose is not required. And time of injection very short, 15 minutes for 1,000 milligram. And maximum dose can be given up to 1,000 milligram infusion. And this can be given. And this increases the hemoglobin rise. So this is basically the robust, can be administered in higher doses. Release slowly, avoiding toxicity and oxidative stress, not associated with the dextran-induced hypersensitivity, short infusion time, and structure stimulated to ferritin deposited into the RE cells. Test dose is not required, and low immunologic potential. So the dose, patient body weight, and the dose, hemoglobin below 35 kg, only 500 gram, 35 to 70 can be given 1,500, 70 kg or more can be given 2,000. And again, when an hemoglobin rise is also important. Why it's very, very important? It should be given in 15 minutes in 250 ml of fluid, and it should not be, we should not delay it. It should be given fast, because there are chances of delay this chelation into it, because the carbohydrate over the molecule, it dissolves slowly in 15 minutes, and after the 15 minutes, sudden rise and there can be a chelation. So it should be given in 15 minutes, and that's very, very important. And if the dose is less, for the less than 35 kg of weight, then it should be given in 6 minutes, 100 ml. So very important. And there are several evidences all over the country, and then in Australia, Switzerland, they have many studies, and they have given where to give it in a pregnancy, and there is a definite rise of hemoglobin up to 3 grams in 3 weeks of pregnancy. Especially all Indian studies are also there. Maheshwari, Mishra, Nagesh, Agrawal, and many studies are there. And they also suggest there is no problem to it. That's another important point. Now there is a comparison of FCM with iron sucrose is very, very important. And they have done the inclusion criteria, 100 patients. They have given the FCM and the rise of hemoglobin baseline after 12 weeks. Again, rise of hemoglobin 12 weeks from baseline was very good. And it is resulted into the rapid replenishment of the iron stores. We are not worried only the anemia part. We are supposed to replenish the iron stores also. That's another important point. And these are another studies. They have also talked about that the infusion corrects the iron deficiency, and a various degree of iron deficiency anemia are safely pregnant. Then again, overall hemoglobin rise is 2.24. That's another important point, and significant increase with 1,000 milligram infusion, and very important. And these are the few studies which I have noted and taken this. There is an absence of hypersensitivity many times, and there is a safety parameters have been said. And this is one clinical effects of safety of FCM have in a pregnancy, and this is very important because the mean gestational age at delivery, mean birth weight, Apgar score, stillbirth, these are all tested. Early neonatal mortality and requirement of hospitalization, and no adverse reaction being seen in this case, this study also. There are another few studies and very important studies for the trials, and this randomized control trials are also there. And there is FER, ASP, just to support all this that we can give it in a pregnancy. That's many studies. Now for these are the Anemia Mukta Bharat guidelines are first level treatment, 2 tablets of iron, folic acid, and daily for the 6 months. Parenteral iron, IV sucrose may be considered, IV iron sucrose or FCM may be considered first line management in the pregnant woman who detected to be anemic and late in the pregnancy, and compliance is little likely to be low. If no improvement after first level of the treatment, referral to the higher health facility. The case may be managed with IV iron sucrose or the FCM. If hemoglobin is 5 to 6.9, first level of treatment, immediate hospitalization and FCM can be given. In a summary, a timely detection and appropriate treatment of iron deficiency anemia can be improved the maternal health. Number 2, can be administered required no test dose, and most studies parenteral iron preparation has vast safety in the database. It's a valuable alternative for the pregnant women, and it can be more tolerant than the oral iron treatment. Single large dose administration, rapid rise of hemoglobin, and favorable safety profile with no related serious adverse effects. This makes the FCM more preferable option in the management of moderate to severe anemia during pregnancy, and during the second and third trimester. It's so well tolerated in a pregnant women with no complications evident into the newborns. So thank you so much. Support me, and thank you so much for inviting and giving me the chance today to talk on the subject. Thank you so much, Emcure, for giving me the chance. Thank you so much.
Thank you, Kavita ma'am. It was very nice and interesting. You have got a lot of comments also. Rajeshri ma'am has commented it's a crisp and very clear. And Vidya ma'am has commented that she's traveling, so she's not able to attend, but she has sent all the best to you, Kavita ma'am. It's a very interesting, very nice. If any questions will be attended at the end of the sessions, ma'am.
Yeah.
I'll not be there. No, Shobha, thank you so much given me the chance, Rajshri. And
Yes,
thank you so much, Nagesh. I'll not be there to listen to you, as well as Mahesh is there. So thank you so much, everyone. And please allow me to go. Anupama, thank you. Over there, Shilpa, thank you so much.
Thank you,
Hi,
ma'am.
Kavita.
Thank you.
Kavita, you
Dr.
did a good
Kavita,
job.
thank you.
Kavita.
Yeah, thank you. Thank you
Yeah,
so much.
yeah. Very nicely presented, anemia. And I'm really surprised that, more Kasogians could have benefited from your talk. It was very
I know.
clear message.
Who listens nowadays on
No,
webinar?
no,
There
this
is a
is
separate
recorded.
link for delegates.
Yeah. There's a separate link for delegates.
Okay.
This is recorded and it will be I'm sure it will be uploaded to the website, isn't it, Rajesh?
Otherwise, this presentation everybody can see on my YouTube channel. So much. Thank you so much.
Thank you, Kavita.
Thank you so much.
Excellent talk
Support
and
me
wish you
and
all the
love you
best.
all. Love you
And
all.
Kavita requesting you to support me too.
Yeah,
Be here.
Thank you so. Thank you so much.
Yeah. Next topic is by introduction of speakers by Dr. Anupama Patil. Next is a debate, which is like drilling of ovary for and against by the two eminent speakers, which will be who are introduced by Dr. Anupama Patil. Anupama, can I share the screen?
Yes, ma'am.
Can you see, Anupama?
No, not yet.
Yeah, just a second.
Very interesting topic. Next one. Large PCOS hands will be itching to do the drilling. So gynecologists have to learn to keep
Anupama,
that.
Can you see the CV?
Ma'am, I have it on my WhatsApp. Shall I start?
Yeah, please start. Please start. Don't waste time.
Yeah.
Good evening,
You want us to share the screen of CVs?
I have it, madam.
Yeah, okay.
Good evening, everybody. I'm very happy to introduce our senior fertility specialist for the debate today. Dr. Mahesh Koregal, sir, is a senior fertility specialist practicing in Nova IVI Center in Bangalore. Sir is practicing since 17 years. He was also the honorary treasurer of Bangalore Society of OPG, honorable secretary of Bangalore Society, chairperson of Reproductive Endocrinology Committee of KSOGA, executive committee member of KISAR, and member of FOXY Endoscopy Committee, and he is member of FOXY, ISAR, KISAR, IFS, ICOG, IAG, and ACE. Welcome to you, sir. Next doctor for the debate is Dr. Dipesh Sorakia. Sir has completed his MS OBG from NHL College, Ahmedabad. Sir is the founder and director of Kushi IVF, Ahmedabad since 2019 and is currently working as the head and director of Department of IVF at KD Hospital, Ahmedabad. Sir has worked at Milan Fertility Center, Ahmedabad, Nova IVI Fertility at Ahmedabad, and Rajkot Medical College. Sir is trained in reproductive medicine at MMM Chennai and is also trained in endoscopy from France. He has presented many papers across the conferences. We are very happy to welcome you today for the debate, sir.
Dipesh, sir, please unmute yourself.
Done, madam.
Yeah. Do we start with Dr. Dipesh?
Yeah.
Hello.
Yes, sir. You can please start sharing your screen.
Yes, ma'am. So it's heavy raining in Ahmedabad, so there is little bit of network issue.
Okay. You could.
Yes, ma'am. Just give me 1 minute. So, as a fertility experts, I really had the laparoscopic ovarian drilling, but today my turn is to speak in the favor of laparoscopic ovarian drilling. So we know that there is an epidemic of PCOS patient that come in our OPD, and we know that everybody is in hurry to get the conception. So we always jump from the simple ovulation induction medicine to the gonadotropin, favoring the IUI, and later on the IVF treatment. But still, there are the class of patients that can't afford the gonadotropin that have we can put them on the this type of the things. So I have put the few slides from the SRA PCO guidelines. So they compare various studies comparing the laparoscopic ovarian surgery versus metformin. So there are the few single center studies that suggesting that there is no difference between the laparoscopic ovarian drilling and metformin drug. Second one, laparoscopic ovarian surgery with clomiphene citrate. Probably none of the specialists from the panel or whatever the delegates now never using the clomiphene citrate nowadays. But there is no changes in the use, no inferiority of laparoscopic ovarian drilling. So, and similarly, clomiphene and metformin, there is insufficient evidence to support or refute the laparoscopic ovarian drilling, plus comparing the metformin and the clomiphene citrate. Similarly, our favorite latrozole aromatase inhibitor, no statistical difference between the two interventions. Most important thing is when you compare the laparoscopic ovarian drilling versus gonadotropin, the laparoscopic ovarian drilling is better compared to the laparoscopic putting the patient on the gonadotropin. So what we follow and the certain guidelines follow is when you diagnose PCOS, don't diagnose on the simple ultrasound. Try to have the measure the AMH before putting the patient on the ovarian drilling. And do not send the patient to the laparoscopic surgeon directly without your presence for the PCO drilling. So always follow the rule of 4 puncture, 4 second and 40 watt in the each ovary. So what favors me for the laparoscopic ovarian drilling is young patient less than 30 years of age with AMH more than 6 years. Patients, particularly when we are subjecting the patient for other indication of laparoscopic like tubal testing or when you suspect other things, and considering the cost of gonadotropin and laparoscopic, both whatever the favors to the patient. So for me, this is the favorable point for the patient who doesn't require the regular monitoring. For those patients who refuse, still wait for the gonadotropin to be introduced in their line of treatment. And another that favors or against, that is the invasive procedure that patient has to go. So I conclude my talk. I am favor the laparoscopic ovarian drilling for the younger patient who are less than 30, for AMH more than 5, more than 6, and we follow the rule of 4 for the PCO drilling cases. Over to the Dr. Mahesh.
Thank you, Deepesh bhai. That was quite modest way of summarizing.
Sir, as a fertility specialist, I never going to touch the ovary because we always have the value of 1 X.
Yeah. I know.
Yes. But the patient who are not affording and they don't want to come from the monitoring, it's art, but it should be judiciously used when we do the laparoscopic drilling.
Correct. Oh, that is true.
Dr. Mahesh, sir, I think you can go ahead with your contest, what you have.
Can you see my slides?
Yes.
My debate is against the ovarian drilling today. And it's very clear from Deepesh's side that it can happen, that there are few circumstances it is advisable. But then today's era of such an advanced ERT and availability of so many different gonadotropins and so many monitoring observations of OHSs and everything, I think the drilling has lost its place. So since it's dinner time, let me start. It looks fried chips are nice to have. Yes, chips can be fried. Fried chicken can be fried. Fried chips everybody loves. Finger chips everybody loves. There are a lot of fried fruits. All of us love a lot of fried foods. And when you come to eggs, yes, fried eggs, different ways of having a hen's egg, yes. But why fry human ovaries? So there is no need to fry up human ovaries, which is very, very prevalent. No matter, we can say that guidelines say 4 punctures, 4 seconds, 4 mm, everything is fine. But then you ask any surgeon who is doing it, most of the times in the peripheries, surgeons are the ones who drill it. So they ask them, what is the indication of drilling? They said, itna acha dikh raha tha, nice ovary we could see, and we could just, because it's a large ovary, so we just put some punctures. So there is no need to fry up human ovaries like this, which will compromise, which will end up with compromising the reproductive potential. So fried food is okay, but frying the human ovaries is absolutely not necessary. See the way all these pictures, see the number of punctures that have been put, see the number of laparoscopic drilling that has been done. So many mishaps like this happen. And these women come with almost reduced ovarian reserve, and sometimes they have to go for a donor egg. So this is a sad part of ovarian drilling, and that is the reason why the ovarian drilling has to be avoided to the extent as possible, because it is having 4 punctures just at 4 seconds with 4 ampere current. It's just like if you want to slap someone, just touch their cheek. So it's just not even slapping. So it's not even useful. So then why do it? It is not even having. So if you have a PCOS, you're definitely going to get this kind of a pattern. So let's talk of evidence. So it's not just what I feel or what you feel. It's what the evidence says. So it's evidence is something that is what we have to do, evidence-based practice. You see the study where an outcome of laparoscopic ovarian drilling with women with PCOS was done. Can you see the conclusion there? It's a 2021 study. No significant difference in ovulation rate after laparoscopic ovarian drilling, which is comparable to published studies. The low pregnancy and live birth rates indicates that additional factors affect the success of LOD. So there are other coexisting pathologies which are associated with the lower rate of pregnancies after laparoscopic ovarian drilling. So you wanted to give benefit by doing a laparoscopic ovarian drilling, but what has happened here is the patients have ended up with a lower pregnancy rate post laparoscopic ovarian drilling. So this is one sad part of laparoscopic ovarian drilling, where the pregnancy rate is going to fall. Let's go to the god of all the evidences, that is Cochrane Baba. Cochrane Baba ki jai. What does the Cochrane says? So we believe Cochrane most of the times. So see, the Cochrane library is a recent Cochrane update on 2020 on laparoscopic ovarian drilling for ovulation induction in women with anovulatory PCOS. So what happens if you do a drilling in anovulatory PCOS? So what the Cochrane Baba says, you see the conclusion are written down: laparoscopic ovarian drilling with or without medical ovulation induction or induction alone. So this pooled results suggest that laparoscopic ovarian drilling may decrease live birth compared to the medical ovulation induction alone. So please, this is a very important slide wherein you are going to harm, in the sense you are going to reduce the pregnancy rate by doing laparoscopic ovarian drilling. So evidence suggests that chance of live birth following medical ovulation induction alone was 42%, whereas laparoscopic ovarian drilling was just 28 to 40%. So it is important that you don't have to reduce the pregnancy rate. Why it happens? The complications of ovarian drilling, why it leads to the lower pregnancy rates? Because iatrogenic adhesions happen, because when you do the drilling from the surface of the ovary, the premature contact between the ovary and the bowel after fertilization leads to bowel and ovarian adhesions. Premature ovarian failure is very prevalent. I myself see so many patients who come with a premature ovarian failure because of the drilling. Because multiple punctures are done, it leads to ovarian blood supply get damaged, and large number of punctures are going to excessive destruction of ovarian follicular pool or production of anti-ovarian antibodies. So these are the reasons many patients come just after the ovarian drilling that their AMH has gone down, their egg reserve has gone down post drilling, and you don't have a choice. What is failure of laparoscopic drilling? What is the definition? How clomiphene citrate failure is there? Laparoscopic ovarian drilling failure is defined as a failure to ovulate within 6 to 8 weeks, recurrence of anovulatory status after an initial response, or failure to conceive despite regular ovulation for 12 months. So the rate of ovarian drilling failure is very high. If it is to fail, then why to do it in the first place? So it is not required to be done. So failure rates are high because they have to conceive within before 12 months or before even 6 months. So this is going to be a challenge, and your surgery is going to lead to more adhesions, reduced ovarian reserve, and a failure. So laparoscopic ovarian drilling is not so great. So you should remember that you should help the patient. If you can't help, as Hippocrates said, at least do no harm. So ovarian drilling is absolutely not useful. Without medical indication, ovulation induction is going to be much better. Evidence says that there may be little or no difference between the treatment of clinical pregnancy when there's uncertainty with laparoscopic ovarian drilling. None of the evidence have justified or have given any good pregnancy rate, live birth rate, clinical pregnancy rate, or miscarriage rate improvement using a laparoscopic ovarian drilling. Sometimes some people have become either only unilateral or a bilateral laparoscopic ovarian drilling was a debate. Then there was no data, there was no justification to do either unilateral or bilateral laparoscopic ovarian drilling. So there was study, 2 RCTs between laparoscopic ovarian drilling versus metformin. There was insufficient evidence to make a recommendation about the laparoscopic surgery compared to metformin for live birth. Per patient, ovulation rate per cycle, pregnancy rate per cycle, or pregnancy rate per patient. So there was no difference. So not to recommend any laparoscopic surgery. If you see laparoscopic surgery versus clomiphene citrate, there was no difference between laparoscopic surgery and CC for live birth rate or pregnancy rate or ovulation rate. Another study for laparoscopic surgery versus clomiphene citrate or metformin, the clearly told that the meta-analysis have clearly found out that clomiphene citrate plus metformin was better than laparoscopic ovarian surgery for live birth rate and no difference in pregnancy. So there was no evidence to support the use of laparoscopic surgery over clomiphene citrate plus metformin. You all have been using metformin over years. You all have been using clomiphene citrate over years. Definitely, this has a much bigger impact and much better pregnancy rate over a laparoscopic drilling. So there are three RCTs compared letrozole to the laparoscopic drilling and found that there was no evidence of a difference between letrozole and laparoscopic surgery. So no need to subject the patients to laparoscopic surgery. Laparoscopic surgery versus aromatase inhibitors with metformin, there is no difference of advantage of the laparoscopic ovarian drilling. So with the comparison with the gonadotropins versus laparoscopic surgery has no advantage over gonadotropins because now such a high level purified recombinant gonadotropins are available. So they give equal or even better rate. So there is no use going to be miscarriage rate or pregnancy betterment with the laparoscopic surgery. So frying ovaries is disaster to reproductive life. So frying eggs at a kitchen with a hen's egg is good, but then not to try frying the human ovaries. Important. What happens if you burn the ovaries? If you end up burning the ovaries, what will happen is the poor patient has to go with the donor egg IVF because so many surgeons do, and they end up with a completely loss of ovarian reserve and they are pushed to donor egg IVF. I'm sure most of you fertility specialists would have seen sudden drop in the AMH and patients have no more ovarian reserve because it's a zeal. The surgeon sees, oh, it's a nice and big and shining white ovary, let me drill it, taka, 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 and then they end up with a problem. So these such kind of add-ons don't work in IVF treatment. Let me drill the ovaries and then do IVF or IUI. Yes, it's curd rice, pickle tastes good. With the pizza, these are all add-ons on the pizza. We can have extra cheese, extra scoops, everything. But this add-on treatment of laparoscopic ovarian drilling is not good in the fertility treatment because remember, first do no harm per Hippocrates because this paper clearly shows that post-drilling anti-mullerian hormones before and after drilling polycystic ovary, so fertility is not going to improve, and then AMH values are going to drop if you are more overzealous with your ovarian drilling. So please control the horses. Don't drill much or don't drill at all ovarian drilling because you are going to drop the AMH levels, drop the ovarian reserve. You are going to cause the adhesions and you might cause the premature ovarian failure. So are you sure over drilling helps? No, if you're not sure, don't help because ovarian drilling cost burden is to the patient. Additionally, if you're going to operate in a corporate unit, more than 1 lakh rupees is charged, which is not necessary. The same amount can be spent on medications, a good gonadotropins, and pregnancy can be achieved. So you should not do harm as a duty. You should accept consequences of our action. So no way it is going to be perfect treatment with the laparoscopic drilling. So nobody is going to have say that laparoscopy is going to really help. So not necessary to do it. Thank you for your time. I hope I clarified the point.
Yeah, thank you, sir. Thank you, Mahesh, sir. So, Dr. Deepesh, sir, do you want to come back with any anything?
So, the only that favors me for the laparoscopic ovarian drilling, if patient is non-affording, they are far from the remote area, and those who don't come for the regular monitoring, that's one of the reason. And if we wanted the laparoscopy for the another reason like tubal testing or anything, most of the patient due to the letrozole or with we have the doctors Sachin sir with the extended letrozole protocol, most are doesn't require usually till the drilling or not drilling.
Yeah. Okay. So I think I will conclude. So the ovarian drilling has limited role in the present infertility practice, and rightly because of the availability of letrozole, which gives monofollicular growth, and also because in IVF cases we have an excellent freezing program wherein freeze all can be done and OHSS can be prevented. So as Dr. Dipesh sir rightly mentioned that the limited role is in non-affordable patients who cannot come for repeated ovulation inductions and who cannot come for multiple cycles. So in young patients, young thin PCOS patients, we can consider this where the LH levels are high. So I think that would be the debate. So Mahesh sir clearly emphasized as to why we should not do it. So it was quite an interesting and quite good points by both the debates. Anything else, Rajeshri madam? Anything else you want to add?
Yeah, I think both of them were fantastic that they just justified what they're doing and why they're not doing. And especially when Dr. Mahesh says that you really don't need to fry the eggs when it is not necessary. And we have had instances in the past, like about 20 years ago, when a lot of drilling used to be done. And just like the picture that he has shown in the PPT, that we have seen many of the ovaries being just burnt out like that. Definitely we need to justify, and with the evolution of many, many wonderful drugs we have on the protocol for ovulation induction and trigger, one should be definitely guarded, and especially not to be done with the surgeons who really do not understand the concept of doing the ovarian drilling. That was a fantastic debate, and I'm glad that you both agreed to take up this debate. And it really triggered off a lot of interesting topics and points. Thank you, Dr. Mahesh, and thank you, Dr. Dipesh. Well, they rhymed well. That is Dipesh and Mahesh taking up the debate. Fantastic.
So infertility specialist is laparoscopic surgeon. So who is doing the drill?
Yes. Yes.
Excellent talk. Excellent talk by the speakers. Let us move to the second session now. And the second session is topic is unexplained infertility and all about trigger. I request Dr. Ashalata Malapur madam and Dr. Nagesh Kumar sir to chair the session. Let me share the CV of those two.
I think Rajeshwari, if you have the slide.
Can you see the slide? Yeah. Asha Lata Malapur ma'am, she's a MD DGO from MR Medical College, Gulbarga. She's a professor at head of Department of S. Nijalingappa Medical College and Hanagal Sri Kumareshwar Hospital and Research Center, Bagalkot. She has a 30 years of teaching experience and she has a rich experience in academic as well as research. We welcome you, ma'am, to chair this session. And we have Dr. Nagesh Kumar Ji, who is a director of Janani Fertility and IVF Center, Tumkur. He is MBBS TGO and DNB. He is a master. He has done his masters in reproductive medicine and IVF from Curtin University, London, UK. It's a FOXY training course. He has taken FOXY training course in reproductive medicine. He has given a lot of lectures and presented many papers in the conferences. In that, he has presented 3D ultrasound as a virtual hysteroscopy, which is a very interesting thing. We welcome Dr. Nagesh Kumar sir and Dr. Ashalata Malapur ma'am to chair the sessions.
Thank you. Thank you, Dr. Shobha. Thank you.
Sir, welcome. Sir.
Rajeshwari, can I have my PPT, please? Can you share my presentation? All right, make it full screen, please.
I request Asha ma'am.
Yes.
Introduce Rashri ma'am. Yeah, I'll just share the screen of Rashri ma'am.
Yeah.
I think that's okay. We can go with the talk.
Okay,
and
I have Rajeshri, and everyone knows Dr. Rajeshri. The Honorable Secretary, KSOGA 2023 and 25, Dean Research in KBN University, Director, Aditya Multispeciality Hospital, Gulbarga, and she's gold medalist and represented Rotary International at Australia from India as a member, GSC team member, postgraduate and undergraduate teacher and examiner for 30 years. Areas of interest are high risk pregnancy and infertility. So over to you, Dr. Rajeshri.
Thank you, Asha ma'am, for those kind words of introduction. And namaste and good evening to all the respected faculty and the delegates who have logged in for today's interesting session of infertility. Ever since the evolution of humanity, I think the most precious and dear ones of the human sciences has been to understand how we all procreate and how is it that we all come into existence. And this is a beautiful orchestrated event which occurs in the female genital tract along with the gametes which fuse in the fallopian tube, and then the implantation occurs. It appears also simple, but yes, it is so complicated because in the past 5 or 6 decades, a lot of effort has been done to understand this concept of fertilization and existence. But alas, we fail in many ways. And when we fail, we call it to be an unexplained infertility. Change the slide, please. Can you allow me to change the slide? Yeah. So fertility, when we call it as unexplained, the couple should have at least 12 months of regular unprotected intercourse for 1 year. This is basically a diagnosis by exclusion, wherein no abnormalities of the female and the male reproductive system are identified by the standard investigations. 25 to 30% of the infertile couples are diagnosed with unexplained infertility. And this is just a humbling experience for all the fertility practicing specialists that although we try to play God and bring in so much of results with so much of permutations and combinations, yet 25 to 30% of the cases remain as insolvable questions. And therein we really put this credit to the Almighty or to the Creator. There is something beyond what we understand. This guideline was put in by the International Committee for Monitoring the Assisted Reproductive Technology. Rajeshwari, can you change? The guideline for the development group, again, has a definition which says that infertility in couples with apparently normal ovarian function, normal fallopian tubes, uterus, cervix, and pelvis. The age of the woman, the upper limit here is considered as 40 years of age, although there is a controversy of this. Some of them consider 35 as the upper limit of the age, with adequate coital frequency of 2 to 3 days interval and apparently normal testicular function. Genitourinary anatomy is normal and there is a normal ejaculate. So looking at the causes of infertility, we have male infertility, wherein the factors are identified in the male, 30%, female infertility, wherein the factors are identified in 30%, combined factors, 25%, others, 5%, and the unexplained, 25%. And these contributory causes can be again divided as unexplained male infertility and unexplained female infertility. The criteria to call it as an unexplained male infertility, one basic semen examination strictly by the WHO's 6th edition manual for examination and processing of the human semen, and the male partner who has had a normal medical history, normal physical examination, the semen analysis is normal, there's no identifiable female factors in the partner, and the average incidence for the unexplained male infertility is to the tune of 15% with a range of 6 to 37%. How do we go ahead? The guidelines development group recommended that a thorough history taking regarding the medical history, the reproductive history, and sexual history from both the male and the female partners has to be noted down. And when the couple is a regular menstrual cycle, it should be of the duration of 24 to 38 days with 8 days of flowing duration and the shortest to longest cycle variation of less than 7 to 9 days. And one basic semen examination according to the WHO criteria of 6th edition. And if this is less than 5th percentile, then a repeat semen analysis after a 3-month interval is always advised. The factors leading to unexplained male infertility are mostly immunological in nature. They could be immune infertility, anti-sperm antibodies, sperm DNA damage, elevated levels of reactive oxygen, genetic defects, sperm dysfunction, vital factors like erectile dysfunction.
Madam?
Can you hear
Rajeshri,
me?
madam? Yeah.
Yeah,
Yeah.
we can hear you, ma'am. Rashmi, ma'am?
Rajeshri, madam, are you there?
Yeah.
Shobha, can you check if she is rejoining?
Yeah, I'll just check.
There's one patient who got a Soumya karke. She's FS scan only, but apparently she's having pain abdomen. She's due for her periods on the 7th. She's having pain abdomen, but she's not getting bleeding. She's put her finger inside and she's caused bleeding. And she wants to take methotrexate. I said, please take it. She's seen online. It says category A, it seems. I said, you're not pregnant. You're MPT negative. Stop.
Can you see me? Shilpa?
Yes, ma'am. Yes, ma'am.
Yeah. Sorry about that interruption due to there was a power failure and the generator backup is on. So we were talking about the factors leading to unexplained male infertility, which could be mainly due to immune infertility, anti-sperm antibodies, the sperm DNA damage, elevated levels of reactive oxygen species, genetic defects, sperm dysfunction, coital factors like erectile dysfunction, inappropriate timing of the intercourse and fertilization defects. The immune infertility is due to autoantibodies which bind to the antigens present on the male or the female gametes. The anti-sperm antibodies induces the functional deficits in the sperms. Anti-sperm antibodies are formed following a breach in the blood-testis barrier as in trauma, infection, or obstruction. Antigens present in the female cervical mucus binds to the antibodies and causes lysis of the sperm cell, reduce motility of the sperms, decrease the ability of the sperms to penetrate the cervical mucosa. So as depicted in the picture, the anti-sperm antibodies are formed due to the breakage of the blood-testis barrier and the epididymal obstruction, which act upon antigens act upon the sperms and the oocytes and thereby cause failure of conception. Reactive oxygen species are the byproducts of oxidative metabolism. The oxygen-free, these could be of three varieties: the oxygen-free radicals, that is the hydroxyl and the superoxide ions; the non-radical species like the hydrogen peroxide and lipid peroxides; the reactive nitrogen species, that is nitrous oxide, nitroxyl ion, and peroxynitrate. Significance of the reactive oxygen species: in small amounts, it helps in capacitation, hyperactivation, motility, and fertilization. But the elevated amounts of reactive oxygen species weakens the antioxidant defense mechanism and leads to the damage of lipids, proteins, and DNA of the spermatozoa, a condition called oxidative stress. The elevated levels of reactive oxygen species in the body are naturally tried to curtail down by the seminal antioxidants such as mercaptoethanol, vitamin E, vitamin C, cysteamine, cysteine, taurine, and hypotaurine. Genetic defects. The genetic mutations and polymorphisms have been recognized in infertile men with normal spermiograms. Examples are Catspia gene 1 mutation and CAG polymorphism. Sperms have reduced oocyte penetration when they are affected genetically, and their ability and fertilization are markedly decreased. Oxidative DNA damage. The commonest cause of DNA fragmentation is oxidative stress, which may be associated with the advanced paternal age, inadequate diet, drug abuse, tobacco abuse, environmental factors such as pesticides, exposure to air pollution, varicocele, and systemic diseases and genital inflammation. The abnormal sperm-oocyte interaction is an intricate and complex process of fertilization. Commences with capacitation, which occurs in vivo during the travel of sperm through the female reproductive tract. In vitro, it can be induced by removal of seminal plasma and addition of the culture media. Investigations for unexplained male infertility, semen analysis, anti-sperm antibodies, tests for reactive oxygen species, chemiluminescence for reactive oxygen species, total antioxidant capacity, Meoxis system to assess the oxidation reduction potential. The sperm DNA damage assays include the single cell gel is the HCD and the halosperm. Male unexplained infertility and 2023, which denied all this investigation, and they say the testing for anti-sperm antibodies is not recommended when the semen analysis is normal. Testing for sperm DNA fragmentation is not recommended. Sperm chromatin condensation test is not recommended. Sperm aneuploidy screening is not recommended. Sperm hormonal testing is not recommended. HPV testing of the semen is not recommended, and microbiological testing of sperm is not recommended. Coming to the female infertility, unexplained infertility in the female partner is ambiguous as in the male partner, and oftenly the factors which are overlooked are endometriosis, tubal infertility, premature ovarian aging, immune infertility, and the incidence of female unexplained infertility is also about 15%. Causes for unexplained female infertility, like the mild forms of endometriosis, undiagnosed tubal factors, premature ovarian aging, immune infertility, oxidative stress, poor oocyte quality, and uterine cavity abnormalities like endometrial synechia, endometrial polyps, and chronic endometritis. Endometriosis in the mild forms can cause the peritubal altered tubal motility and function, toxic effect of peritoneal inflammation on the sperms and oocytes, and reduced endometrial receptivity. Uterine cavity abnormalities per se do not cause, the malformations do not cause infertility, but they usually cause the reproductive loss. But defects like septate uterus and bicornate uterus and arcuate uterus are seen to the tune of 20 to 35%. Immune infertility, production of autoantibodies specifically directed towards the ovarian antigens, especially against the beta segment of the FSH, and there is an overall activation of the immune system. The autoantibodies cause premature ovarian failure, polycystic ovarian syndrome, tubal infertility, endometriosis, and unexplained infertility. So the investigations for the female unexplained infertility, hormonal assays like FSH, LH, anti-Mullerian hormone, prolactin, and TSH, ovulation studies like follicular monitoring and serum progesterone estimation level, tubal patency tests like hysterosonosalpingography and hysterosalpingo contrast sonography, laparoscopy. uterine cavity assessment by transvaginal sonography, and there is a lot of emphasis on 3D ultrasound for the assessment of the uterine cavity and hysteroscopy in indicated cases. So the recommendations for diagnosis by ESHRE guidelines for the confirmation of ovulation is the estimation of the LH levels, the ultrasound monitoring, the mid-luteal progesterone monitoring. Next. For the corpus luteum quality, it is not recommended to do a mid-luteal serum progesterone and the estimation and the endometrial biopsy. For the ovarian reserve, with regular menstrual cycle, testing for the ovarian reserve is not required. Tubal factors are determined by doing the HSG and the hypoC. The chlamydial antibody testing can be considered in low-risk patients and visual demonstration of the tubal patency in high-risk patients. Uterine factor 3D ultrasound is recommended to explore the uterine anomalies, and laparoscopy as a routine diagnostic test is not recommended for unexplained infertility. Cervical and vaginal factor, the postcoital test is not recommended in couples with unexplained infertility. Vaginal microbial testing could be considered in research setting only. And male genital urinary anatomy, the testicular imaging is not recommended when semen analysis is normal by the WHO criteria. Additional tests for systemic conditions like anti-sperm antibody in the serum of male and female is not necessary. Testing for celiac disease in women is recommended. The TSH measurement is a good practice and no additional thyroid evaluation if the TSH is of normal level. Testing for thrombophilia in women is not recommended, and testing for oxidative stress in semen of male is considered only in research context. Genetic and genomic testing is also invalid, and testing for vitamin deficiency and prolactin doesn't hold a stand. So what could be the treatment options? Because it is a very ambiguous in nature, and then we just need to offer a protocol empirically. The evidence-based treatment as per the ASRM guidelines have a permutation and combination of various oral medications for the ovulation stimulation along with IUI. So next slide. The treatment options are empirical. The ASRM guidelines have many combinations which have been described, like natural cycle with intrauterine insemination, clomiphene citrate with natural intercourse, aromatase inhibitors with intercourse, gonadotrophins with intercourse, clomiphene citrate with IUI, aromatase inhibitors with IUI, combination of clomiphene citrate or letrose and gonadotrophins, that is a low dose and conventional dose with IUI, low dose gonadotrophins with IUI, and conventional dose gonadotrophins with IUI. Next slide. But the first line of treatment remains ovarian stimulation with oral medications, either the clomiphene citrate or aromatase inhibitors for 3 to 4 cycles with intrauterine insemination. And consider the IVF if there is a failure of the IUI treatment. Active treatment is gonadotrophin for stimulation only in low dose with adequate monitoring, and IVF is individualized by patient characteristics like age, the duration of infertility, previous pregnancy, and previous treatment that the patient has received. ICSI is not recommended, and conventional IVF is the treatment of choice. Mechanical surgical procedures, hysteroscopy for possible detection and possible correction of intrauterine anomalies is not recommended routinely. The HSG using oil-soluble contrast medium and its possible benefit of tubal flushing should be discussed with the couple, and endometrial scratching is not offered as per the ESHRE guidelines. So what could be the therapeutic alternative approach? Adjunct oral antioxidant therapy in men and women is of no use. Acupuncture is rarely helpful. Inositol supplementation in women, probably not useful. Psychological support and psychotherapy has a definite role, and healthy diet and regular exercise with behavioral therapy is highly recommended. In vitro fertilization is recommended by NICE guidelines for all patients who fail to conceive after the expectant treatment for a period of 2 years, and considered to be the most effective method of treatment as it helps with ovarian dysfunction, cervical factors, abnormal sperm-oocyte interaction, and tubal dysfunction. Expensive and invasive, yes, but then it has the additional risk of, also has a high risk of multiple pregnancy and OHSS. IVF is probably the most effective management strategy, which may be used once 3 to 6 cycles of ovulation induction and IUI have failed. It also provides an opportunity. In fact, the IVF is a real test to see whether the gametes are normal and they're able to have the fertilization, and to rule out the poor oocyte quality and abnormal sperm-oocyte interaction, which would otherwise have remained undiagnosed with the currently available tests. Next slide. Having done all that, but still there could be implantation failure because there could be impaired receptivity of endometrium due to cellular and molecular defects. Recurrent implantation failure when there is a failure to conceive after 3 IVF attempts with good quality embryo, and a detailed workup has to be done to understand the reasons for the failed implantation. Causes for the recurrent implantation failure: most importantly, the autoimmunity, the presence of autoantibodies, the raised TPO-ATG levels, the reduced NK cell, CD56 and 16 levels, presence of anti-nuclear antibodies, the thrombogenic status, aplopositive status, karyotypic abnormalities, genetic mutations that need couple exome sequencing in PGT-A and M, and HLA matching of the couples has to be done. And when this exceeds 25%, then the chances for implantation taper down. Having gone through the entire reasons of it, and it is a very simple take home 4 to 5 lessons in unexplained infertility. The diagnosis is empirical. The routine investigations for male and female infertility, that is the oxidative stress, immunological factors, and genetic abnormalities are the important contributing factors. The best initial therapy is 3 to 4 cycles of oral medications for ovulation stimulation along with IUI. And IVF suggested for failed stimulation with IUI. There is a pressing need for additional therapies to bridge the wide gap which exists between the IUI and IVF, and research is further needed to improve the access to care and IVF. So I thank you all for the patient hearing. That end of the day, all that is needed is a baby to take home. Thank you. Thanks for giving me this opportunity.
Thank you, Rajeshri. Very well explained and very nice.
Thank you, ma'am. Thank you, ma'am.
I request Dr. Nagesh Kumar to introduce our next speaker, Dr. Sachin Dalal, sir.
Good evening to all of you. Now I welcome Dr. Sachin Dalal, who is a consultant in IVF and gynec endoscopy. He is affiliated to Madhu Hospital, Fortis, and also Embryona IVF. He has won many marks awards. His areas of interest is in teaching infertility concepts and also laparoscopy. So I welcome again Dr. Sachin Dalal to speak all about trigger. Is a HCG trigger or analog trigger or a dual trigger. Over to you, sir.
Thank you, Dr. Nagesh, for that kind introduction. Can I share my screen? Okay, so at the outset, I would like to thank the office bearers of KSOG, Vidya ma'am, Rajeshri ma'am, and Shilpa ma'am for having me here for this fantastic CME. So I will not waste any time. Today, what we are going to talk about is all about the ovulation trigger. Before we go for the ovulation trigger, we need to understand the LH surge. What happens in the LH surge in a 20 to 30 day cycle? 14 days before the expected ovulation, the estrogen levels begin to rise. This will trigger the GnRH pulses from the hypothalamus, thereby inducing LH from the pituitary, causing the LH surge. The LH binds to the LH receptors on the granulosa cells, and it induces oocyte maturation and ovulation. What is the aim of the ovulation trigger? One, to mimic the LH surge for final oocyte maturation, obtain optimal number of mature M2 oocytes, and to provide the luteal phase support. Actually, there is some background noise. Can everybody mute themselves? I am having a lot of disturbance here. Yeah, thank you so much. So what are the most common triggering agents used? One, we use HCG. Two, we use GnRH agonist. HCG, as we all know, of two types, urinary and recombinant. GnRH agonist, luprolide, acetate, and triptorelin. Now, when we look at the chart, the efficacy and the longevity of the each molecule, as we can see from this slide, the highest duration of action is of HCG, which is almost 6 days, followed by the natural LH surge, which is for 36 to 48 hours, and the bare minimum is the with GnRH agonist, which is only 20 hours. Coming to human chorionic gonadotropin HCG, it has been our favorite since years. It stimulates the LH receptor due to similar molecular structure. HCG administration causes granulosa cell luteinization, switch from estrogen to progesterone synthesis, resumption of meiosis, oocyte maturation, and subsequent follicular rupture. However, we need to keep in mind that HCG has a slower plasma metabolic reactions compared with the natural LH. Estimated half-life of HCG is more than 24 hours, while estimated half-life of LH is only 60 minutes. Thereby, we need to keep in mind the OHS's risk possibility whenever we are using the HCG trigger. When we compare urinary versus recombinant HCG, as we all know, urinary comes from the urine of pregnant women, while a recombinant is from the genetically engineered Chinese hamster ovary cells. Urinary has lack of purity because of the uncontrolled source, while recombinant has a controlled source. It is created in the lab, so thereby ensuring that it is a good quality with good purity. In urinary, we will find batch-to-batch variability, which is not there with recombinant HCG, since it is purified by repeated chromatography. Therefore, urinary is very economical compared to recombinant, which is much more expensive than urinary. So there are papers which compare each of the molecule. One paper suggested that urinary HCG is better than recombinant HCG in the parameters of number of retrieved ovaries and number of M2 or fully mature oocytes. While the second paper showed that whether you use recombinant HCG or you use urinary HCG, there is absolutely no difference. So finally, whenever there is such a doubt, we always fall back on our old Cochrane. Cochrane says that yes, recombinant HCG was associated with an increase in the number of retrieved oocytes and reduction in the incidence of local site reactions and other minor effects. However, most important, there is no evidence of a difference between rec HCG and urinary HCG regarding ongoing pregnancy or live birth rates, clinical pregnancy rates, miscarriage rates, and incidence of OHSS. Coming to the next molecule, that is GnRH agonist. It is a synthetic peptide similar to hypothalamic gonadotropin releasing hormone. Acts on the GnRH receptor, causes release of FSH and LH. So this needs to be kept in mind that where we are giving HCG, it only gives a LH surge. GnRH agonist gives a FSH as well as LH surge. There is an initial flare response followed by prolonged pituitary downregulation. Bolus of GnRH agonist displaces the GnRH antagonist attached to the receptor and induces a flare-up of FSH and LH, causing oocyte maturation and ovulation. However, GnRH agonist can only be used in GnRH antagonist IVF ICSI cycles. It cannot be used in GnRH agonist or the long agonist cycle. When we compare the two molecules, that is rec-HCG versus GnRH agonist, they found that there is almost similar outcomes in terms of number of oocytes, number of mature oocytes, and the 2PN oocytes. Also, when they did a comparison of GnRH versus HCG for live birth rate, it was almost the same. But the most important difference was when Cochrane compared all the studies available, and they found that GnRH agonist has a profound effect in prevention of OHSS comparison to HCG, therefore becoming the first choice of molecule in triggering in patients who are hyper responders, in donors, and in PCO women. However, there is a problem with GnRH agonist since it acts directly. It has apoptotic effect on the granulosa cells. It causes early corpus luteal demise, thereby having a profound luteal phase deficit. So we need to replace the luteal phase with either HCG or estrogen and progesterone to maintain the estrogen and progesterone levels secreted from the corpus luteum when we are using just a single GnRH agonist trigger. So Humaydan et al. Came with another profound, brilliant idea where they combined GnRH agonist with a low dose of HCG 1500 to 6500 international units. They found it decreases the risk of OHSS by reducing the dose of HCG. It is more physiological since because of GnRH agonist, there is a FSH peak which will generate a large number of mature oocytes, whereas HCG alone will only have a LH peak. It extends the ovulation time after HCG, thereby improving the oocyte maturation rates. And because we are giving HCG, we are supporting the corpus luteum. There is a better luteal phase recruitment when it is combined with use of HCG and GnRH agonist. So looking at various papers, this was dual trigger in high responders and poor responders. And in both the arms, they found that GnRH agonist with a HCG, that is a dual trigger, had a better pregnancy rate, better implantation rate, and definitely better take-home baby rates in both high responders as well as poor responders. Another paper, they found that when you are doing a dual triggering with agonist plus HCG versus triggering with HCG alone in GnRH antagonist cycle, they found that the favor is definitely in favor of GnRH agonist plus HCG, that is the dual trigger comparison to the HCG trigger alone. Then somebody came up with another bright idea where they said that instead of giving both the injections at the same time, how about keeping some gap of 6 hours between the two? So what they did is they gave GnRH agonist at 40 hours before the pickup, and after 6 hours they gave HCG before the pickup. This has been suggested to improve IVF outcome in patients with a low proportion of mature oocytes retrieved in the previous cycle. This acts by prolonging the interval between the trigger and the oocyte retrieval, which has been described as a strategy to increase the M2 oocyte yield. Also, the FSH surge with GnRH agonist may overcome the impairment in the COC complex function, oocyte meiosis maturation, and cumulus expansion. When we look at the spectrum of response to ovulation trigger, what we aim to is the thing in the middle, that is optimal oocyte retrieval. However, we might have in some cases a low retrieval rate, especially in women with advanced maternal age, poor on ovarian response, and in the hypo patients, while in hyper responders, in PCO women, and in polymorphism patients, we can occasionally have a OHSS causing a great problem. Then there is this major problem that we IVF specialists occasionally come across is the empty follicle syndrome. What happens in empty follicle syndrome? We've given the trigger, we are doing the pickup, and when we are doing the pickup, there are no oocytes, there is no COC complex from the fluid that is withdrawn from the ovarian follicles. 33% is genuine, for 67% is false empty follicle syndrome. The reasons for the empty follicle syndrome are: one, HCG trigger problem, GnRH agonist trigger problem. Root causes is the human error. Patient has not diluted well, she has not taken it properly, it was not stored well, it was not injected well. High BMI of the patient, low baseline LH levels, and less bioactive LH. Looking at false empty follicle syndrome, it is usually seen in HCG related faults where there is issue with HCG timing injection, failure of HCG injection, improper injection technique, poor cold chain. There are occasionally batches of HCG which are really bad. Especially post COVID, I found that HCG 5000, which we used to give initially for triggering, the patients would just not have a follicular rupture. So after that, since past 3 years, I've completely given up HCG 5000 and gone over completely to HCG 10,000 for triggering, and that problem is reduced. It can also be because of rapid metabolic clearance, manufacturer defect, low bioavailability of HCG, and of course, individual variation in threshold for follicular response to HCG. Genuine empty follicle syndrome, that is not much that we can do. It can occur with early oocyte atresia, where the follicular stimulation has not been good enough, absence of oocytes due to increased apoptotic gene expression, ovarian aging and low ovarian reserve, and probable inherited mutation in LH-HCG receptor familial cases. So what do you do in a patient where you have an empty follicle syndrome? What to be done next? What you do is you re-administer the HCG and do a second pickup after 24 to 36 hours. So how we do is, you have given the trigger, aspirate from one follicle only, don't go to the other follicle. If the follicles show an empty follicle from one ovary, repeat the HCG trigger and then do the pickup from the other ovary after 24 to 36 hours. You can prevent this by assessing the serum LH and progesterone levels on the day after the trigger. There has to be a prolonged interval between trigger and oocyte pickup. I think I've got a slide on that. Change the HCG brand. Definitely check your cold chain. The gonadotropins have to be in an exclusive refrigerator. It should not be in a refrigerator which also has food and other food stuff and water and ice cream inside the fridge. Use of double trigger strategy, that is GnRH agonist trigger after HCG trigger, and use of recombinant HCG. So how long to wait after the trigger? This was a nice study which found that maximal oocyte retrieval is between 35 to 37, 38 hours. But in our patients, we found that if we go beyond 36 hours, sometimes we find that some of the follicles have ruptured on their own. So the best sweet spot is between 34 to 36 hours. I usually do between 35 to 36 hours and have got expected oocyte retrieval as per the stimulation. Looking at the key factors in the success of the trigger: one, timing of oocyte retrieval; two, the ovulation trigger agent; and three, the pre-ovulatory follicle to mature oocyte ratio. So this is one last slide where I will be talking about trigger practices at my center. For all poor and normal responders, it is always urinary HCG. If I'm doing IVF, it's followed by a fresh ET with a standard luteal phase support. We'll be using dydrogesterone and natural micronized progesterone 400 milligram BD or TDS. If I have got more than 15 mature oocytes, then in that case we will be doing a freeze-all and doing a FET cycle in the next cycle. If it is a hyper responder or donors, it is always a luprolide 2 mg trigger, no HCG, and freeze all. However, if I feel that it is a hyper responder, but she's not responded in a very hyper way, she has responded just in a normal way, what I usually do is give a dual trigger and do a fresh ET with modified luteal phase support. Or if again we've got more than 15 oocytes, then do a freeze all cycle. Thank you so much.
Yeah, thank you, sir. Thank you so much. The chairpersons, Nagesh sir, would you want to say anything?
Yeah, it was a very nice lecture, and he has clearly discussed about different types of triggers and advantages and also disadvantages. So thank you, sir. Any questions?
Sir, I would like to ask one question, sir, to Sachin Dalal, sir. Sir, you said you will do a pickup, you are doing pickup at 35, 34, 35 hours. So what is, I just want to ask all the seniors, what is the ideal time? Is it 34 hours or 35 hours? Who is doing it 34, 35? I have this confusion. I am doing it 34 hours, but sir said at 35 hours. So I want to ask Sachin Dalal, sir.
So as I told, I usually give my trigger at night 11 o'clock and do all pickups at 10 a.m. in the morning. Okay. So it's almost always 35 hours for all my patients.
So usually what we're saying with HCG 10,000, if we have 5 to 6 follicles, usually they rupture at 34 and a half hours, something like that. Beyond, I've seen rupturing of follicles.
So I mean, individual variations are always going to be there. What, as I mentioned, is you have to find your own sweet spot in which time frame your patients are, maturing or they are rupturing. I have found that if I'm doing it 35 hours, hardly ever I have had a free fluid in the POD at the time of pickup.
This actually happens in elderly patients. This premature ruptures. So maybe we can time around 34 and a half hours in elderly patients. So
elderly patients, yes.
Yes.
Agree. Agree.
Okay. Sir, anything trigger, is it going to change the quality? M1, M2 is okay, sir. Anything related to the quality of the oocyte, like granularity, cytoplasm things, or
granularity, granularity I'll mention some time ago. This was pre-COVID. I had a particular brand of Cetrolix which I was using, and in that patients we found a very dark colored cytoplasm in the oocytes. However, they formed blastocysts. So I used that for a few patients, and when I switched the brand to back my original brand, and that dark colored oocytes completely stopped. Another thing, as we talk about oocyte quality, it all is a matter of the age, the AFCs, and the AMH. Also, what gonadotropin you are using. in case you have a representative who's coming from the pharma and telling that I'm going to give you a HMG for 1.5 rupees, don't fall prey. If it is an expensive HMG, it is going to be good. So you stick to those standard 2-3 leaders in the pharma industry, whereby you can be assured that one, their manufacturing processes are very good. The QA/QC is maintained. They do a batch-to-batch bioavailability studies and assays, which you can ask them and they will give that to you. Four, they've got standard distributors who are maintaining the cold chain in your particular area. A lot of time they come with a nice sealed box with a temperature logger, so that can ensure that during the entire thing the temperature was well maintained during the transit. And in your center, as I mentioned during my speech, that have a separate dedicated refrigerator for the gonadotropins, wherein there are only gonadotropins inside and nothing else, and have a small thermometer stuck to the refrigerator. It's available on the e-commerce sites for around 300-400 rupees. So you will be able to assess the temperature changes that are happening inside the refrigerator. Being a part of the NABH, we had to put it, and it's really useful for all the fridges where you're going to store the gonadotropins.
Sir, any difference between triptorelin and leuprolide trigger you found? Any difference between trigger of triptorelin and leuprolide?
Dr. Mahesh, I didn't expect this question from you, but yes, it is asked on all the groups and multiple times. I have done in the same patient donors given decapeptyl trigger in the first instance, in the second instance given a lupride trigger, and trust me, same response. And this is the sentiment which is echoed by a lot of other doctors across the country, that when you are using triptorelin and leprolide, it's absolutely the same. Why I like luprolide per se individually over triptorelin is triptorelin comes as 0.1 milligram injections. So if you want to give a 0.2 or 0.3, the poor patient has to take 3 pricks. While the lupride comes with a fantastic 0.5 ml. Sun has come with lupride new, especially for triggers. So there is only 0.5 ml fluid. So the patient is getting injected hardly 1 ml or 1.5 ml, depending upon whether you're using 2 mg or 3 mg for trigger. So you can do yourself in your own center, have similar cohort of patients, give half of them triptorelin and half lupride, and see. I found that it's absolutely the same.
Any repeat dose after 12 hours of first trigger?
Never. See, this is a very common question, Dr. Mahesh, again asked by a lot of people, that I have given a trigger and after that the follicle is not ruptured. So should I give another shot of injection? What we have to see is when
not that question. What I'm asking is, for an IVF egg pickup, you give a leuprolide trigger or a triptorelin, and 12 hours later you give one more. Whether the maturity of the oocyte you find, not because of the rupture. 36 hours later you posted it.
No, actually, if you look at literature, a single trigger given 36 hours before causes the FSH and LH surge. So how is a second trigger physiologically going to help? Because your 2 milligram trigger, or in obese patients, I use 3 milligram trigger, your FSH and LH surge has already occurred. So do you think that after giving a second dose of trigger, there's going to be a second FSH and LH surge? So I think it's just for our mental satisfaction that give a second dose of trigger after 12 hours or 24 hours. But physiologically, I don't think there is any effect. Rather, what you have to do is do it right the first time. Keep your gonadotropins in a safe place and use only 1 or 2 brands, so that when your staff does not have to call you that, sir, isko main kya injection do. Like if you open my refrigerator, there is only 1 brand of HMG, there is only 1 brand of Rec FSH, there is only 1 brand of trigger. So the staff does not get confused. That is the most common problem that occurs in a lot of standalone IVF centers, where there is this injection problem that occurs, that instead of giving HCG, patient has been given something else.
There are papers, because I spoke on the same topic in Chennai. There was a paper which says that adding either agonist trigger or you add any FSH also at 12 hours post trigger, the maturity of the oocytes is going to be better. Maturity is what many papers are coming up, and many practitioners are also practicing. 12 hours post the first trigger, you give another additional GnRH agonist trigger. Is what is something new. Is what I wanted to.
This is, I mean, every year we see that new trends which are coming in. and going out, after a lot of research and counter research, and finally Cochrane comes saying that that is not very important. So what I would suggest is, if you feel that this is good, you can try doing it in your own patients and see if it is helping. If you're finding that the FORT is better, giving a second dose after 12 hours, you can definitely do it for all your patients. I mean, nothing against it, but physiologically does not sound logical. Sorry
Thank
to say.
you. Yeah, thank you so much, Dr. Sachin Dalal, for that extensive overview of ovulation trigger. And just that the momentum has built up and we are so well geared up for everything now. We have Dr. Varsha Baste who has joined in. Welcome, Dr. Varsha Baste. And during our talk,
Hello.
she just
Hello,
flew
everybody.
from Nashik to Nagpur. So as our talks were going on, she has landed in Nagpur and then she's all logged in and she's here to give us a talk on fertility preservation in malignancy. And I think that would summarize the kind of fertility issues that we are dealing for today. Welcome, Dr. Varsha Baste, and over to you, Asha ma'am.
Thank you, dear. Good evening.
Good evening, ma'am. Asha ma'am, please. Yeah.
Welcome, madam.
Thank you, Dr. Shilpa and Dr. Dipesh. I am really thankful to everybody, KSOGA and all the organizing committee, Dr. Rajashri, Dr. Shilpa, and everybody, Dr. Mahesh. Thank you for accommodating me at the last, because my flight got delayed and now I'm there to deliver my talk. Thank you so much.
Madam, slides, please, to introduce madam.
Yeah, you have to share the slides.
Yeah, just a second. I'm just sharing.
Yeah, I welcome Dr. Varsha Baste, madam, a practicing gynecologist. Practicing gynecologist and infertility specialist in Nashik since last 30 years. Director of Baste Maternity Hospital and Pushpa Fertility Center. First IHC and PGD baby in North Maharashtra in 2003. Past president of OBGYN Society Nashik 2014. Chairperson of Foxy IAEC in 2019 to 2022. She has received a prestigious Dr. Anandibai Joshi Award, amongst we for Street Puraskar by Honorary Government of Maharashtra, Foxy Champion of Foxy Award, Foxy Excellence Award for outgoing Foxy Chairperson, organized many national and international conferences. She's participated in numerous national and international conferences, founder member of MSR Maharashtra ISAR, life member of IAG, fellow ICOG and FICOG, diploma in infertility, KEIL University, Germany. So welcome, madam.
Thank you, Dr. Ashalata, madam. Thank you so much. I can see Dr. Shobha Gudi, my dearest friend, also there. And yesterday also we had a wonderful webinar. Thank you so much for inviting me and giving the opportunity to talk in front of this August gathering. So now, Dr. Rajashri, can you share my talk? Thank you, Dr. Ashalata, madam, for giving me nice introduction.
I think the slides are with you, ma'am.
I have sent you on mail also.
I will share this to the event organizer.
Rajeshwari.
Yeah, Rajeshwari.
Hello, Dr. Shobha.
Hi, ma'am.
Rajeshwari, I have sent the slides to you. Can you please share?
Meanwhile, I would like to thank all the KSOGA organizers. I can see Dr. Mahesh also. Dhanyawad, sir, for joining, and you have increased the glamour of this webinar. And Shobha, also I can see Dr. Shilpa. Thank you so much. Dr. Dipesh, Dr. Nagesh Kumar, sir, Namaste ji. And Ashalata, madam, Dhanyawad. Sachin Dalal, I just listened to him. Excellent talk, very nice. Thank you so much. I could hear it a little late, but it was really, the conversation and the interactions were awesome. Really, very many take-home messages about HMG and HCG. Rajeshwari, Neha,
Thank you, ma'am.
Pandit, thank you so much. Okay.
Yeah,
So,
Rajeshwari, can you please share the slides of Madam Varsha? I have sent it to you.
Ma'am, I'm sharing the slide.
Yeah, please do. Neha, yes.
Yeah.
I will make it short also, if you want.
Ma'am, give me 2 minutes.
KSOGA is always very near to my heart for its academic standards. I had attended Hubli convocation ceremony and it was wonderful and awesome by Dr. Hiremat sir, Nagarajan sir, and so many, Dr. Hema Divakar, really wonderful, Dr. Vidya Tobi, so many stalwarts under one umbrella in Karnataka. The standard of Karnataka KSOGA is very, very high. I will say it is parallel to Foxy. You are all working. Nice to.
Oh, thank you, ma'am. Thanks for this words of appreciation.
His president is special, Dr. Shilpa, Dr. Vidya Kobi. We are really good friends and working very hard.
Yeah, I would like to take this opportunity to just tell that KSOGA has about 20 committees, and this is today's webinar done under the Infertility Committee. And in the past 100 days that we have taken over as the regents of the KSOGA Association, there must have been more than 50 academic events which have occurred, and definitely we are reaching out to the society, and we just have had the Safe Motherhood Committee do the reach out programs regarding anemia, diabetes, and hypertensive disorders. And this is a session which is being conducted for the healthcare professionals and the lab workers to educate them more about the anemia and the other diseases which are prevalent at the grassroots level. Over to you, ma'am. Varsha, ma'am.
Thank you so much. Can you make it bigger or is this way only? Okay. So my talk is fertility preservation in cancerous conditions. Every time, every decade, or what I say, every 4 and 5 years, the change in treatments and new modalities one has to acquire. So this is like a new thing which we have to acquire as ART specialist. Oncofertility, the science of collaboration between reproductive medicine and oncology. Cancer affects approximately 10% of reproductive women. Preservation of fertility and having a biological offspring is an important desire for cancer survivors. Because nowadays the young cancer survivors are there and the fertility, they also want to have their offsprings, and it is natural in and so the cancer patient have to undergo fertility treatment before subjected themselves to these treatments. Next, please. Next slide, please. So the guidelines have been formed by ASHA. Also has declared the guidelines, and guidelines for fertility preservation is, if the treatment includes cancer surgery, the following options should be considered, like fertility sparing surgery, preserving gonads, preservation of uterus in females. Use of cryopreservation may also be considered prior to surgery if the risk of gonadal damage is high. If she has to undertake the treatment of radiotherapy to pelvic organs or gonads, shielding aiming for reducing the damage of reproductive organs, and surgical ovarian transposition nowadays is followed. Because surgical ovarian transposition will protect the surgeries from this radiation exposure. Use of cryopreservation may also be considered prior to radiotherapy. Then if the treatment includes cytotoxic treatments with high risk of gonadal damage, use of cryopreservation methods such as sperm banking for males and freezing of embryos or oocytes for females and gonadal tissue freezing is done prior to say subjected to these cytotoxic treatments. And if the treatment include hormone therapy for estrogen sensitive breast cancer, then anti-estrogenic drugs are given. So cryopreservation may be considered to women who are more than 33 years of age when a 5 years tamoxifen treatment is planned, because tamoxifen reduces estrogen, and so it is the anti-cancerous treatment or drug of choice for cancer, and one has to give it for more than 10 years also if she is more than 20 years of age, when 10 years course of ATLAS is planned, as natural fertility diminishes with age, and also this drug cause effect on the gonad. So prior to that, cryopreservation is recommended. Next, please. So ASHRAE has come up with a very nice guidelines, and they really are very, very helpful for counseling the patient for treatments, and also after treatment, after the patient is taking cancer, anti-cancer treatment, what about fertility treatments, the options they can have and how to go about it. So ASHRAE has formed very good guidelines and they are followed all over the world. So can I have the next slide? So these are the guidelines model of ASHRAE. So it gives us like clinical care, what type of clinical care patient needs, who is undergoing the the cancer treatments. Then comes the support and counseling. It's very, very important. We have to select the patient according to their problem, age, and what treatment modalities they are going to undergo. And then comes the after fertility reproduction treatment. So what type of treatment they need and how to counsel them when they should go for reproduction. This is all in detail. ASHRAE has formed guidelines, and we have to follow that, and that gives a complete what we say package of the treatment prior to treatment, during treatment, and after treatments, and it is really helpful. Next, please. So the actual fact that cancer treatment is the most frequent cause of reduced fertility in cancer patients. Up to 80% of survivors are affected because of the cancer treatments. None of the established or experimental fertility preservation can assure parenthood. Rather, they may provide future opportunity to overcome treatment-induced sterility. Around 70 to 75% of young cancer survivors are interested in parenthood, but the number of patients who access fertility preservation technique prior to treatment are significantly low, because the doctors only do not have the knowledge where to send the patient, whom to send, and where what treatment modalities are available. So moreover, despite existing guidelines, healthcare professionals do not address fertility preservation issues adequately. Lack of time and knowledge about existing options, delaying potentially useful treatment, patients' age, partnership status, existing children, sexual orientation, and socio-economical situation are the main barriers to effective fertility preservation. Next, please. So patients' fears, expectations, and priorities shaped by personal values have addressed in frame of medical necessities, realistic survival probabilities, socio-cultural environment, and research abilities are so important to think about. We call for a need of patient-centered fertility counseling within a framework that should include patient understanding of medical aspects of their cancer, realistic fertility preservation options. They should be counseled for realistic fertility preservation options, preferences based on personal values and goals. Optional support services should also include legal guidance, psychological and spiritual support, and also financial counseling is also very, very important. Next, please. So these are the actual facts. So the significant points to discuss are magnitude of problem of each as a patient is different. The impact of the disease and therapy on gonads and gametes. Currently available methods of protection and preservation of oncotherapy-induced gonadotoxicity without compromising the effectivity of cancer treatment, because we have to treat her with the treatment also. So I have taken 3 cases, but we will not discuss it in detail. But these types of patients come for counseling or treatments. Case 1 is 33-year-old female known for BRCA mutation positive, recently diagnosed with invasive ductal carcinoma. Her oncologist informed her gonadotoxic treatment chemotherapy she will have to undergo. She wants fertility preservation. How to proceed? Because she is BRCA2 mutation positive, and radiotherapy also is the gonadotoxic chemotherapy are anti-estrogenic. So before starting the treatment, she should be given advice for fertility preservation. Next. The case 2 is 39-year-old married male recently diagnosed invasive ductal carcinoma, tumor excised, plans to start chemotherapy next week, is informed possible gonadotopic effects of chemotherapy. He wants fertility preservation as he desires to have second child. How to proceed? How many samples of sperms to be cryopreserved? Now the question is very well addressed that how many samples of sperms? It is not 1 or 2, but minimum 10 samples should be cryopreserved to have good fertility preservation. Next, please. She is an 18-year-old unmarried girl diagnosed first stage of CA breast. FNAC confirmed diagnosis suggested surgical as well as chemotherapy as management of lobular lump in breast. What advice one should give to her about future fertility preservation? What is the role of modified protocol as dual stimulation? So these are the questions the patient may ask you, or these are the situations one has to tackle as patient to patient. Individual treatments or individual modalities, each one should be handled and given the fertility, the cafeteria of the treatments. Next, please. Next slide, please. So let us see the impact on male fertility. Male infertility is due to treatment results in anatomic problem, that retrograde ejaculation following surgical intervention, hormonal deficiency following radiation or chemotherapy, damage or depletion of germ cells due to chemo or radiotherapy. So compromise sperm number, motility, morphology, and also DNA fragmentation. So we have to cryopreserve the semen sample before starting any type of chemo or radio treatments for such patients. Next, please. So general procedure for male fertility preservation is mostly sperm preservation with cryopreservation. The collection is done before start of any therapy of cancer treatments. Gonadal shielding during radiation therapy is advised, and testicular tissue cryopreservation or testis xenografting is advisable. Next, please. And what is the impact on female fertility? Chemotherapy and radiotherapy that will decrease the follicular number, hormonal dysregulation will occur, alter ovarian, uterine, or tubal functions, increase oocyte aneuploidy. So surgical procedure also cause anatomic or vascular damage of uterus, cervix, vagina, preventing natural conception. So such patients need ART, and anatomical damage may also occur from disease. Please. So these are the problems one has to face while handling such patients. Next slide. So what are the fertility treatments before cancer therapy is initiated? She can go for oocyte cryopreservation or embryo cryopreservation, ovarian cortical tissue cryopreservation. If she is not married, she can go for oocyte cryopreservation. If she is married, embryo cryopreservation. Gonadal shielding during radiation therapy, ovarian transposition is advised nowadays as 50% chances of altered blood flow and scattered radiation. Radical tracheotomy in early cervical cancer is advised, and best is embryo cryopreservation. We all know that embryo cryopreservation is the best modality of fertility preservation. Next, please. But we have to actually tell the patient what is the significance and how much will be the outcome. Sir, what are the modified methods for gamete freezing? control ovarian stimulation induce supraphysiological levels of which are detrimental to hormone-dependent cancer like breast cancer. So modified methods like GnRH antagonists, letrozole, tamoxifen protocols are used for such patients. Next, please. What information to tell patients the success of fertility preservation? It is very, very important. You shouldn't keep the patient in cloud nine. Chalo, hum fertility preservation karte and you will be having everything all right after your treatment is anti-cancer treatment is over. Nothing like that. Patient should be informed with frozen embryo transfer. Success rate is 30 to 40% of pregnancy. It is not bad, but they should be informed. Written consent should be taken. It is very, very important. The legalities, many forms are there to be filled up for such patients. And for pregnancy for vitrified oocyte is only 5 to 7%. So also the problem is that this cancer patient have increased metabolic state, cancer associated cachexia, increased release of cortisol may affect hypothalamus-gonadal axis. So the patients also are a little compromised than normal patients. Next. So what treatment to offer when the patient is on anti-cancer treatment already started or about to start? So this patient, the impact of the cytotoxic drug on follicular depletion is also follicular atresia, low E2 inhibin, FS is also compromised, and recruitment of primordial follicle is also problematic. So we have to start the treatment before the initiation of treatment always, but at the same time, the cancer treatments are also to be given if needed. Next. So patient has to come during intramenstrual period. Is the random start? Or can we do that? The modified concept is that we all know multiple waves of follicular recruitment within a single interovulatory period is there. So late follicular start or luteal follicular start, we can have more number of oocyte preservation with any start like late follicular start. We can use with GnRH antagonist, aromatic inhibitor, and gonadotropins. We can have oocytes. Then again for after 3-4 days, we can again start with luteal phase start, and we can get more recruitment of follicles. So that multiple ways we can take advantage for such patients because the time is very, very important for them. Next. So what are the current modalities of male fertility in preservation? Sperm cryopreservation, macro-TC, MESA, pre-pubertal boys, cryopreservation of testicular tissue and spermatogonial stem cells to avoid DNA damage before start of cancer therapy is very, very important. Next, please. So the take-home message is compared to male, fertility preservation in female is more complicated. Chemotherapeutic drug decrease female fertility up to 80% with use of cyclophosphamides, busulfan, methotrexate, taxanes, etc. most commonly used drugs. Embryo cryopreservation is most promising. Unmarried girl, oocyte cryopreservation most popular naturally. Ovarian transposition is promising, but more studies are needed. In Vadia and in Tata, the ovarian transposition is more promoted. Ovarian cortical tissue cryopreservation too is a better option. Antagonist instead of agonist, letrozole, tamoxifen used for control over stimulation is to avoid hyperestrogenism. Dual stimulation for more yield of oocytes. If possible, delay to start cancer therapy and do fertility preservation as priority, but it is dependent on case to case. If it is possible, definitely fertility preservation should be given priority and then to start cancer therapy, but you have to take a call. Next, please. So future of cancer therapy will be cell-specific target therapy. So completely it may eliminate need for fertility preservation. That is also a new hope for us, but it is good also. But at present, we have to go for fertility preservation. Thank you. Thank you for your patient hearing. Next slide, please. This is the hospital where I am working. I am Dr. Varsha Baste from Nasik. Next, please. And dear friends, I am going for the Vice President Foxy West Zone. So please bless me, support me, guide me, and vote for me. Mera chehra dekhna aur sikka marna. Thank you. Thank you. Over to you, Dr. Rajashri.
Thank you very much, madam.
Thank you, madam.
We sincerely hope and best wishes for your elections to come. And this was a very informative talk, because with the rising trend of cancers that we come across in the young population of the girls, and also the girls who are trying to delay their fertility, the cryopreservation is the call of the day. And thank you very much for that elaborate talk. Madam Asha.
Madam, it was very wonderful talk, and need of an hour, so many patients they may have cancer, and they may want to have conceive. So really a wonderful presentation, madam.
Thank you, madam. And now cancer, even if they are not cancer patients because of delayed age of marriage, endometriosis and whatnot, many indications are there for fertility preservation. But I have restricted only to the cancer patients. Thank you for giving me the opportunity.
Thank you so much.
I'm sorry for the disturbances of voice, but I'm sorry, I'm sitting in a public area in airport.
Oh,
but that is the beauty of the current modernization that we live in, and maybe we couldn't have.
Thank you so much. Love you all. Bye.
Thank you. If there are no questions to the community and vote of thanks.
Yeah, ma'am, Dr. Shilpa is busy in an emergency. I'll be doing the vote of thanks. Ma'am, I'm thanking Dr. Vidya Dabbi ma'am, who's a KSOGA president, and Rashri ma'am and Shilpa for organizing this webinar. And I'm thankful to chairpersons Shobha and Gudi, Anupama Patil, Asha ma'am, and then Nagesh sir for chairing the sessions. And the speakers are also were wonderful and very enthusiastic. Kavita ma'am, Sachin sir, Deepesh sir, Mahesh Koregal sir, and we are and Rashmi ma'am, we are thankful for the wonderful sessions and your patience presence. Thank you very much. It was a wonderful evening with a lot of academic feast. And we will be meeting in another KSOGA webinar. Thank you very much, ma'am.
Thank you, Dr. Shobha. And thank you all for joining and patiently staying back for nearly 2 hours plus. It has been more than 2.5 hours, because the talks were so wonderful, the speakers were wonderful, and without much publicity, we could get a lot of delegates logged in today. And I believe there were more than 450 delegates who have come to watch this wonderful webinar. Thank you all and good night.
Thank you, ma'am. Thank you.
Thank you, Sachin sir. Thank you, Nadia.
Thank you so much.
Thank you,
Thank you
ma'am.
so much for having me.
Wonderful.
It was great. Nice.
Yes. Thank you, sir. Thank you, Ashram ma'am.
Thank you, everybody.
Thank you.